Good morning. Another interesting topic is cyanosis. Cyan means bluish discoloration. So bluish discoloration of what? Skin and mucous membranes. So this has been classical teaching that cyanosis has to be divided into two watertight categories like central cyanosis and peripheral cyanosis. But nowadays it is not the case so. Some etiologies may spread between these two. Central due to systemic causes, peripheral due to local causes. But as far as our knowledge is concerned, especially when you are appearing for exams, either in final year or going for postings in second year, we have to keep in mind that this arbitrary classification helps us to some extent, especially related to systemic etiologies. Systemic etiologies can be divided into organ wise: cardiac, pulmonary, CNS, and hematological. So cardiac wise are right to left shunts. Most of the times they are congenital heart diseases. So any congenital heart disease with right to left shunt where deoxygenated blood, that is reduced hemoglobin, if it is transferred without getting saturated in the lung, then it can produce cyanosis. Similarly, any shunts like arteriovenous shunts in pulmonary vasculature or bronchial pulmonary venous shunts which completely bypasses oxygenation pathways, or in severe hypoxia, especially at high altitudes, that is more than 10,000 feet. You know one syndrome that is known as Monge syndrome. Those permanent residents who are living at high altitude, especially those who are living more than 12,000 feet, throughout their life, they become cherubic, means plethoric facies, polycythemia, and sometimes right ventricular hypertrophy because of pulmonary arterial hypertension. So, long-standing hypoxia can lead to cyanosis, and in such high altitude individuals, this is a compensatory phenomenon. You know one thing, cyanosis usually manifests whenever reduced hemoglobin. Reduced means nothing but deoxyhemoglobin when concentration exceeds 4 or more than that grams per deciliter. So this is absolute, means at any point of time this hemoglobin concentration, that is reduced hemoglobin concentration, exceeds 4 grams per deciliter, cyanosis begins to manifest. Of course, cyanosis may not match with the saturation that we are occasionally measure with our pulse oximeters, especially in dark skin individuals like down south. If you are measuring cyanosis, unless SaO2 is falling less than 70, you may not suspect cyanosis. So I stress again that always history and physical examination is more important than simply relying on one pulse oximeter or looking for some other investigation procedures. So other causes are shunts within the lung parenchyma, sometimes with the cirrhosis also. With the cirrhosis, there is opening of these AV malformations or fistulas that can happen between even portal vein and also pulmonary vein. So these can shunt the deoxygenated blood right from the venous circulation to the arterial circulation. So other causes are CNS causes. Depressed respiratory drive sometimes can lead to cyanosis, especially in the setting of heart failure, and rarely you can see either acquired or genetic, where instead of ferrous form our hemoglobin is in ferric form, Fe3 plus. In such settings you can see cyanosis along with acquired sulfamyoglobinemia. So these are the etiologies for central causes of cyanosis: cardiac, pulmonary, CNS, hematological. I included cirrhosis in the pulmonary setting itself because of the shunting of the blood. Okay. One common misconception is poisoning with a carbon monoxide can lead to cyanosis, but it is not so. Because this carbon monoxide, when combined with the hemoglobin, actually it produces bright red color instead of cyanotic tinge. That's why any person who is exposed to fumes, especially gasoline fumes, if they are found unconscious, apparently they look normal and they simply die of tissue hypoxia. In them, we won't see any cyanosis. So this is one of the exceptions because of the color of carboxyhemoglobin itself. It is bright red in color. So carboxyhemoglobin never produces cyanosis per se. Okay. Let us come back to peripheral causes. Peripheral causes are attributed to local causes like cold, producing intense vasoconstriction, especially you might be knowing Raynaud's phenomenon. Second one is either arterial or venous obstruction, which can lead to increase in interstitial fluid and also obstruction of lymphatic system. They can lead to local cyanosis and a redistribution of blood flow away from the non-vital structures like skin. So how to distinguish central cyanosis from peripheral cyanosis? The classical teaching is that if mucous membranes are affected, it is central cyanosis. If they are not affected, only skin is affected, it is peripheral cyanosis. But it is not so much straightforward. What happens is sometimes in completely decompensated heart failure, in pulmonary edema, there is a mixture of both central and peripheral cyanosis. And second thing is, this mucous membranes examination is quite helpful, especially in dark-skinned individuals. For example, as told earlier, pulse oximeter may not detect cyanosis or desaturated hemoglobin till the saturation falls less than 70. In such settings, examination of oral cavity might be helpful. Okay, got the point? We'll go to next slide. Dear students, already I have highlighted this point. Whenever absolute deoxyhemoglobin, not relative, remember, it is not relative to normal oxyhemoglobin, but any cutoff of, but any value of 4 or more than that can produce cyanosis. That's why in anemic patients, whenever hemoglobin is already low, say around 6 or 8 or 10 also, you may not see cyanosis in spite of extensive reduced form. On other hand, what is the other condition, opposite one, polycythemia, where there will be excessive production of RBC cell mass. In such settings, at this cutoff itself, even though hemoglobin might be 17 or 20, you will see cyanosis. Okay, I reiterate this point. Absolute cutoff of 4 grams per deciliter is the most important thing, that is the cardinal feature of cyanosis. Also, we had touched upon this point earlier, hypertrophic osteoarthropathy related to cyanosis. In long-standing hypoxia, periosteal joint swellings do happen, especially long bones. What are they? Knee joints, ankle joints, shoulders, kind of those things. Because of this hypoxia and hypoxia-inducible transcription factors and downstream cytokines, various growth factors like VEGF, platelet-derived growth factor, all those things, these are all theories that you can tell in viva. They lead to proliferation of diaphysis. Remember, it is not metaphysis or epiphysis. So there will be painful swellings. Means arthritis, like not arthritis. It is not arthritis because it is not involving the joint. It is involving the periosteum of diaphysis. So typical classical description is arthritis-like features. So what are those features? Swelling, pain, kind of those things. So if you are seeing a patient with hypertrophic osteoarthropathy, suspect malignancies. Though there are some benign conditions which can lead to such an entity, definitely one has to rule out malignant etiology. What are those conditions which can lead to typical hypertrophic osteoarthropathy? Most of the malignancies, especially lung cancers, also other conditions like mesothelioma, they can lead to hypertrophic osteoarthropathy. Bronchiectasis, cirrhosis, they also can lead to hypertrophic osteoarthropathy. Okay, got the point? So dear students, coming to the final section of cyanosis, already we had touched upon this clubbing and its pathophysiology, though nobody knows clear etiology and pathogenesis so far. Assumed to be local growth factors and also systemic growth factors like VEGF, PDGF, like platelet-derived growth factor, kind of those things. But one interesting variety I would like to discuss. Most of the times, because of systemic causes, clubbing is bilateral. but in few conditions it can be unilateral. What are they? I just tried to summarize into 3 broad categories. One is vascular, second one is neurological, third one is occupational. Especially those patients who are on dialysis, means hemodialysis, they have one fistula here adjoining artery and vein, usually in the forearm. So it can lead to increased blood flow. So in that affected hand, sometimes patient can have clubbing. So dialysis related AV fistula can lead to clubbing. Second one is anything that interferes with the subclavian artery, either anatomically or physiologically. So anatomically, any pancreas tumor, physiologically, any aneurysm, means involving the vessel wall itself, that might be because of giant cell arteritis also. So in such settings, increased blood flow can lead to local release of growth factors, leading to unilateral clubbing on the affected side. Okay, got the point? Second one is neurological ones. Hemiplegia means unilateral paralysis of a limb. Sometimes in such hand or lower limb, one can see clubbing because of the disturbance in the local blood flow. Another one is peripheral nerve injuries. Peripheral nerve injuries can be of any type, like brachial plexus injuries or leprosy, kind of those things. In such settings, perturbations, means disturbance in blood flow, can lead to unilateral clubbing. Last one is classical dysfunction in jackhammer's profession. So always they are working with one hand, beating another one. So when that arm is overutilized, that hand can develop clubbing, means swelling of the soft tissue around nail beds. Okay, today we are breaking down the respiratory system. If you want to master more clinical scenarios like this, click the subscribe button so you don't miss our next high yielding breakdown.